let me ask you this, Geoff. Why do you do psychotherapy?
Why do I do psychotherapy?
Sure, well, right? So, the statistics are such that it leaves you in the minority of psychiatrists.
Well, why do I do psychotherapy so along those lines?
Makes you an aberration.
Right. It's good. I think it's number one. If other psychiatrists aren't doing it and I'm doing it, it sets me apart from other providers.
Yeah, and I find the same thing. And in fact, I get lots of patients who come to me saying, oh, my last psychiatrist, they weren't listening to me. They gave me this diagnosis after talking to me for 20 minutes, and I don't even think it's the right diagnosis. And
I actually had that exact same encounter just yesterday. I had a new patient come to me, and they were seeing a variety of different providers, and each one of them had something different to say. There were some that suggested genetic testing, which was very limited in utility for the patient. Generally, there's actually a number of providers who really just don't use evidence-based methods of treating patients' conditions. In fact, it's more symptom trigger. So if there's a patient that says, "Oh, I'm feeling depressed," okay, let's give you an antidepressant. If the patient's feeling anxious, let's give you a medication for anxiety. Could be a benzo, could be gabapentin, could be an SSRI if they're very advanced, which is really a standard of care, or it could be hydroxyzine.
Right.
Or then a patient says, "I'm having difficulty concentrating," and then they're given a stimulant or maybe Wellbutrin, without really going into too much detail. So when you incorporate psychotherapy as a prescriber, you expand your toolkit of what you're going to do with this patient next, or what you're going to educate the patient about, what you're going to ask more, how you're going to explore what exactly does the patient mean when they say they're feeling anxious, and then you actually diagnose a condition. So that's a hiccup that I've been finding that many providers get into, is they start treating symptoms as opposed to conditions, like major depressive disorder, generalized anxiety disorder. And there's also a misnomer too, when providers actually convey to other providers who they're treating and what they have. They use umbrella terms like, "Oh, this is a however-year-old patient with depression and anxiety." Okay, well, what does that mean? Is
depression and anxiety?
Are those circumstances that they're in, is that just describing their mood in the moment, or is that
sad does not equal depressed, right? So
I could be anxious that I have an
panic disorder. Yeah.
Right, like I could be anxious that I have an assignment due in what previously when I was actively in training programs, I would be somewhat anxious if I had to present in front of people, or if I was being graded, or if my interview was being evaluated,
which actually might not be abnormal. And in fact, no anxiety is a problem.
Right? Do I need hydroxyzine because I'm anxious to speak in public?
If you have no anxiety, then you don't make sure that the trash is out on time, and you don't make sure that you study for your tests, and you don't make sure that you pay your taxes, right?
Right. Yeah. So there's a range of normal, there's a range of abnormal, and so when you incorporate psychotherapy into your practice, you can actually get to the root cause of what's promoting or contributing, or like what's contributing to the patient's current state of being. And if their current state of being is totally super anxious and their functioning is declining, and they just find it difficult to go to work or complete assignments or meet family obligations, their relationships are suffering, and they actually meet criteria for a specific anxiety disorder, then you know what you're working with, and then you can refer to guidelines and say, okay, well, here's pharmacotherapy, here's your first line treatment, here's your second line treatment. here's what it means to go through a full first line treatment and a full second line treatment and so on. But when you incorporate psychotherapy, now you may not even need to adjust medications all that frequently. You can reassure and educate the patient that, yes, you're actually on the correct medication. This is a totally fine dose. Your symptoms have actually somewhat improved. Why don't we actually enhance your coping skills? Why don't we look at maybe some cognitive distortions that may be present and actually educate them on those particular subjects so that they treat their own anxiety instead of take higher and higher doses of Zoloft.
I don't necessarily prescribe to all my patients. I prescribe to many, the majority of them. But often what I'm doing with the medications is I'm treating the symptoms enough with the medications that I can actually begin to apply psychotherapy. So for example, the intensity of the flashbacks may actually reduce once, somebody with PTSD is on the right medication regimen, but you still need to address the trauma. And what gets me there is what gets me to the place where I can address the trauma is the medications, but the last 90% might actually be the psychotherapeutic treatment. That's
it would
doing
be
the trick.
it would be preventing symptoms that would be interfering with the therapeutic process. So if someone would get so triggered, talking about a specific traumatic event, if that's where the session was going, being on a medication can actually reduce that level of distress to not have a totally full-blown panic attack, but maybe just have some moderate discomfort while talking about it, versus the sweating, the pounding heart, the out-of-body experience, but dissociation.
Yeah. What you were talking about was also sort of interesting. You were talking about diagnosis, which of course I agree with you. It's a prerequisite to the most effective treatments is knowing what you're dealing with diagnostically. But I think an interesting almost dialectic of a psychotherapeutic approach is that, yes, we want to name your diagnosis because that's going to give us a lot of information. That's going to give us access to the evidence base around it. But at the same time, I'm now going to look at you as an individual and sort of incorporate all your individual experiences and your history and your background and your own way of thinking about things and parental teachings, and all these other factors and what neighborhood you grew up in and what that was like, to sort of hone my understanding of you even beyond diagnosis.
And in addition to it honing your own understanding of the person, it actually creates a meaningful connection between you and your patient so that then your patient feels like you really understand them, and any recommendation that you do have is based on a very holistic, grounded understanding of their psychological workings. Whereas in brief visits, if providers would have brief visits with patients like 10 to 15 minutes, and they're solely looking at, checking off boxes next to next to criteria within disorders and making very concrete adjustments to medications, there's a much greater risk of non-adherence in that respect, because the patient just doesn't have faith or believe that you really know them and that you're just rushing through another appointment as they feel like they're on an assembly line and this is their next stop on their assembly line, and they don't even feel like a person. You said treat your patient as an entire human being, as a full person,
right? In other words, it's the relationship between psychopharmacology and psychotherapy is really bi-directional. So psychotherapy may actually, be facilitated if you can get your patient on the right medication regimen, but psychopharmacology can also be more effective, both in that, approaching your patients as entire people can help you connect to them, can help you understand how to present information to them such that they understand it and they accept it and they recognize it as helpful, as useful information, can even empower them to kind of take part in the process of
in the decision-making
in
process.
the decision making, right?
And actually communicating to you, oh yeah, actually, you know what, that is in line with my values. I appreciate that very detailed explanation that you gave me, and I understand now that it's not going to be an entire cure for what I'm going through. And even though they may be worried it might change their personality or, you know, cause some adverse effects, you can put all of that into perspective for them so that they understand, you know, what are the changes I'm likely to expect being on this medication. Now, it's not necessarily psychotherapy, but that's more of the psychoeducation piece. But still, that in turn could actually be a supportive measure, because you're building your therapeutic alliance, you're building trust with the patient, establishing yourself as an authority, and communicating to them in a way that they can receive the information, because that's what we do in psychiatry. We're supposed to be experts in communication, in conveying, even as doctors or any other healthcare professional. Education is a cornerstone in medicine.
And I think it's inherent to a psychotherapeutic approach that there's a collaborative aspect to it. Although I think it should be inherent in a psychopharmacological approach that there's a collaborative aspect to it. I believe that sometimes providers who haven't been explicitly trained in psychotherapy don't know, not necessarily through any fault of their own, but don't know how to establish a collaborative approach. And so I think that even just being trained in psychotherapy can enhance your skills as a provider and enhance your patient's trust in you, and dare I say it, even how well the medications will work.
So are you saying that just because you would be incorporating psychotherapy into your psychiatric practice, it doesn't necessarily mean you have to do 50 or so minute visits? You can actually do psychotherapy in shorter visits. Is that what you're saying?
I think you could incorporate psychotherapeutic techniques and approaches and outlooks into shorter visits.
So people shouldn't be discouraged, like if they're, say, working in a high volume practice and they have very brief time, they have very short visitation times with their patients, that they shouldn't be discouraged to stray away from learning psychotherapy techniques, that actually psychotherapy techniques could still be helpful in their working relationship with patients that they have, even if it's in a brief visit.
Absolutely. Even the way you open the session, or the way you present the medication recommendation, right? So, are there prescribers out there who do an evaluation, let's say an initial evaluation, come up with a diagnosis and say, okay, I want you to take this medication at so many milligrams, so many times a day? Yes. Is that the best way to present a patient with, a prescription? No. And I think that, psychotherapy training is going to help people to recognize that even something as simple as a medication recommendation can be turned into a choice that the patient can take part in, and can be presented in ways that are going to be more helpful and palatable for patients, and even enhance adherence, right?
Yeah, I'm sure that would eliminate a lot of frustration for a lot of folks, because studies have shown actually that the most commonly prescribed medications in psychiatry, the SSRIs, are actually no better than placebo for very mild to maybe even moderate depression, and really are most effective for people who are experiencing severe depression. So you have an entire subset of people who really compose the majority of people seeking psychiatric care, whose symptoms may not be severe enough for SSRIs to really make so much of a difference. And then what do people do if they tried an approach and it doesn't work? They may drop out. They may stop taking the medication. They may stop seeing their provider, and they just may say, well, psychiatry just isn't for me.
Having other tools beyond just the pharmacy, right?
Right. Like what else are you supposed to do if a patient says, well, I guess medication isn't for me, maybe psychiatry isn't for me? If someone were to have these other approaches, psychotherapy, that is, for multiple different modalities, there could be more interaction, there could be more engagement, there could be more opportunity to facilitate change or build understanding or clarify certain life circumstances, build awareness, help the patient build awareness of how they're feeling, and even helping them problem solve from time to time.